Good evening to all our Endo Summit Live peeps that are out there, and welcome not to Endo Summit Live, but tonight to Adenomyosis Live. Please welcome Dr. Antonio Gargiulo and Dr. Andrea Vidali, who are the brothers of my Endometriosis Summit team. But Dr. Gargiulo, welcome. Can you introduce yourself a little bit?
Hi there. So I'm like Andrea, I'm a reproductive endocrinologist, and we share a deep interest in surgery since time immemorable, and endometriosis surgery particularly. I work at Brigham and Women's Hospital in Boston. I'm originally from Italy as well as Andrea, and I've been here at Brigham for about 25 years now. I've been involved with your amazing Endometriosis Summit efforts since the beginning. I've been very lucky because of that, because I think I've met incredible people, learned a whole lot.
We think we're lucky to have you. We never expected the Harvard surgeon to join us. Dr. Gargiulo did our live surgery last year. Dr. Vidali, in case anyone doesn't know the endometriosis surgeon, can you just quickly introduce yourself?
Good evening, everybody. My name is Andrea Vidali. I am a reproductive endocrinologist, a reproductive surgeon, and also reproductive immunologist. So I wear many hats, and I think that has helped me, gain a deeper understanding of some of these conditions, not just for what pertains pain, but also fertility, immunology. So I think this has helped me, I guess, mature and learn. And also thanks to the Endometriosis Summit, I have also learned a lot. I've learned a lot from Antonio, actually, and I've learned a lot from Sallie. So I've learned a lot from all of you guys.
Right. So we are so happy to have everybody here tonight. If you are joining us on Zoom, you can try to ask questions in the Q&A box. If you are on Facebook, you can try to ask a question on Facebook, and we'll see if we can get to it. Sometimes it's a little technology issue. The other thing is somebody sent me a question, so hopefully we'll be able to answer that. Now, I met with Wonder today, which that's an underwear for people who need it, ONDR. And they said one of the things they loved about the Endometriosis Summit is that we approached everything: surgery, lifestyle, physical therapy, diet, emotional, gaslighting, psychology. And so we love that. So tonight we have two surgeons on, but I picked two surgeons who really approach adenomyosis as a whole person disease and not as just a cut and it goes away. So Dr. Gargiulo, why don't you kick it off by telling us what adenomyosis is?
So adenomyosis is the presence of endometriosis, which is the abnormal presence of cells and structures that resemble the lining of the endometrium, but outside of its normal location. And particularly in this case, the presence is within the wall of the uterus. And so it's endometriosis that strikes really at its core, the center of reproduction, where obviously the fetus will be growing. And as I was saying just a few minutes ago on the Twitter live, the Instagram live that you put out, it's adenomyosis. Frankly, even though it's been with women for probably thousands of years, it's an emerging condition, because the reality is that it used to be something that the pathologists identified after the uterus was removed. Now we are facing adenomyosis at different stages, different locations during the reproductive years of women. And overall, although one cannot generalize, because you can have adenomyosis at every age, adenomyosis tends to present more commonly in women in advanced reproductive age. But advanced reproductive age, meaning over age 35, it's now reproductive age. The term advanced reproductive age is socially antiquated, because the reality is that an enormous number of women will not even have started attempts at conception before age 35. So that's truly well into adenomyosis, adenomyosis time. So we are starting to see adenomyosis more because the technology for the diagnosis, the imaging technology has changed significantly and exponentially, frankly, over the past 20, 30 years. And even ultrasounds and magnetic resonance imaging, so MRI, has really changed. People have to understand that just like your TV and your phone has changed in the past 10 years, so have our ultrasound machines, our MRI machines, everything has changed. And so what we're able to see now, we couldn't see 20 years ago and sometimes even 10 years ago. So now we're seeing adenomyosis in women that are presently trying to conceive. So it has become now a condition that affects women in reproductive age. And what we have seen is that it has a tremendous impact on live birth rate, miscarriage rate, implantation rate in IVF, and complications of pregnancy, including abnormal placentation. That means the making of the placenta, the exchange organ between the fetus and the mother. And so it can really significantly impact the reproductive process to the point of signifying almost an absolute uterine factor infertility, so that the uterus can be completely wiped out as a functional organ by the presence of this infiltrating endometriosis of the uterine wall.
That is awesome. I wanted to ask now Dr. Vidali. Dr. Gargiulo talked a little bit about the reproductive symptoms and issues with adenomyosis. Can you speak, Dr. Vidali, to the what may create pain and quality of life issues in the person with adenomyosis?
Just like endometriosis is an inflammatory disease, so adenomyosis is an inflammatory disease. But sometimes things can be even more complicated. And let me tell you, of course, it's not the Olympics of suffering, but what happens with adenomyosis is that these islands of inflammation are buried deep inside the uterus, and they expand, they enlarge. They have no outlet to speak of. Okay, endometriosis, sometimes you have an implant that sort of can grow silently for a long time. Adenomyosis has a tendency to be in the uterus. As it expands, because it's buried deep into the muscle of the uterus, this inflammatory reaction can cause uterine, secretion of prostaglandins, and the prostaglandins cause uterine contractions, and the contractions cause pain. The ongoing inflammation causes chronic pain, active pain, pain with menstrual cycles, abnormal bleeding depending on the location. So this general picture of severe pain, which has a tendency to be central. Adenomyosis classically is central pain in the center. Usually individual will point clearly to their location of the uterus, and that's where the pain is. But wait, there's more. On top of the local symptoms, you have the systemic symptoms, which come from having a very advanced and aggressive inflammatory conditions. And then you'll have hematological changes, which we will discuss, but systemic symptoms, an example, fever of unexplained origin, night sweats, signs of inflammation, bloating. You'll see all of those other symptoms that are typical of advanced adenomyosis. And here you have what I call the adenomyosis syndrome, which is the pain, the bloating, and the systemic symptom, which is also laboratory associated with some very specific changes, one of them being the elevated white count, but we'll talk more about it.
So it's very interesting. As a patient, I can say you've never had such bloating in your life till the adenomyosis tries to kick your tush. It is really a very aggressive, very inflammatory thing. I've seen people who have had the diastasis recti from the bloating of the uterus. This is what people report when they have heavy bleeding and heavy clotting and the cramps that nauseate you, because I think there's some interplay between the uterus and not only S2, 3, and 4, which generate pain in the back, but also some interplay with the vagus nerve and the central nervous system. So let's talk about it, Dr. Gargiulo. It used to be so simple as you look at the junctional zone and wham, there you have it, that you have adenomyosis. But that isn't such the case. How do we diagnose adenomyosis? What's definitive diagnosis, and what's something that could lead us to believe somebody may have adenomyosis?
Well, of course, you know, the clinical suspicion is important. You know, the triad of advanced reproductive age, so over 35, abnormal uterine bleeding and pain and dysmenorrhea is, you know, raises the suspicion right away. And we should say right away that there are two techniques, both of which in the right hands are excellent. One is ultrasound, of course, and the other one is MRI. And it really depends on, you know, who is your radiologist, who is the team that you trust that will do the diagnosis for you. And there are signs that can lead to an accuracy, the published accuracy from, and of course, the people that publish tend to be experts. It's almost 98%. Well, in radiology, you know.
Right, in radiology. Sometimes AbbVie likes to get a little involved in publishing, but yes, in radiology.
But there are papers that on both the ultrasound and the MRI that show a 98% accuracy, which is of course very, very high. And what they see are things that are very similar. For example, the change in volume that tends to be asymmetrical, but can be symmetrical, but it tends to be asymmetrical, an asymmetrical change in volume. The change in structure, the ultrasonographer will say is a dishomogeneous pattern in the myometrium. That means that instead of being, you can imagine like the myometrium as a layer of muscle. So it should be in every point, more or less, should be having the same ultrasound characteristics, like it should respond to sound and bounce off sound. That's what ultrasound diagnostics do in a way that's similar. Instead, with adenomyosis, you have these dishomogeneous characteristics. In fact, you can have areas that are frankly different from what the surrounding myometrium should be, to the point that they can form cystic area. That means areas that contain fluid. This fluid, when we see it surgically, tends to be, in fact, very similar to the fluid that we see in, let's say, an endometrioma. So that is hematine-containing fluid, that is fluid containing iron and proteins, containing iron and protein deposits. And you have this microcystic appearance of the myometrium that you can see in ultrasound, and you can definitely also see in MRI, because the MRI measures the density of tissues, and the MRI therefore will also be able to see these microcystic appearances, the change in thickness, density, shadowing of the tissue. Now, you were mentioning the issue of the junctional zone. The junctional zone is more of an MRI issue. And for many, many years, this, you know, we've all been taught classically that the thickness of the junctional zone was per se a very good indicator, if not even a pathognomonic finding. That means like almost 100% sure finding of adenomyosis when that thickness was, say, above 12 millimeters, which is a very arbitrary number. But it turns out, with a very good study in the European Journal of Radiology of 2019, that even that general concept of a generalized thickness of the junctional zone doesn't correspond to real adenomyosis, because they did this a large study in which they then looked at the MRI results and compared it with histology, which means what the pathologist would say. And they've seen that the simple thickness of junctional zone does not correspond at all to a high prevalence of adenomyosis.
Antonio, do we want to explain what the junctional zone is? Because, you know, patients like, oh, my junctional zone, but they don't really understand that. You know, like, I think that we need to explain what that
so
means.
In the junctional zone, imagine it would be nice to have would be nice to have a graphic.
Well, you could share your screen anytime, Doc.
All right, I will do it at some point. I'm gonna
right.
while Andrea.
Also,
Antonio, what I'm gonna do? Can I share my screen, Sallie?
Wait, can I just remind everyone that if you still have your entry to the Endometriosis Summit, which is open for 10 months, that you can go in and watch Dr. Gargiulo's full presentation with his slides on our platform, and it's mind-blowing. I have a question from the crowd, and it goes to some of what you just spoke to, and that is, can you explain the difference between focal adenomyosis and diffuse adenomyosis, and perhaps explain what an adenomyoma is?
Yeah.
Antonio, I'm going to share a picture while you talk, okay? Sallie, Can I share something?
Yeah, it should be on.
So I'll answer this, but I don't want to forget the concept that, okay, for example, here it is. This is an MRI picture, of course, of a diffuse posterior adenomyosis. That means the entire posterior aspect of the uterus is made up of tissue that obviously by MRI, you can see is different from the one on the front. So this is the front of the uterus with a small fibroid, but otherwise normal, completely normal structure of the muscle. And this should be just the same. So this green curve should curve down here where the arrow,
this is the lining, the red part.
That's the lining of the uterus. And for example,
the front and the back are very different in thickness.
Right? Yeah, see, very different. And you can see the cystic structures here. They call it the lacunae, right? And all of this that Andrea is pointing out. Are you doing this live, by the way, Andrea?
Yeah, he's good like that.
Yeah. So all of this that he's pointing out, this is all adenomyosis. Now, this area here.
Which one, Antonio?
Oh, I'm sorry that I have my arrow, but I cannot see. Yeah. All the area that you see with the lacunae, that's all adenomyosis, right? So all that area, that's called diffuse because when you have a whole area of the uterus like this that cannot be circumscribed that easily, that's a diffuse adenomyosis. We talk more of focal adenomyosis when it's much smaller and you can actually think of removing it. So whenever I think of focal adenomyosis, I think of something that can potentially be surgically approached and removed, because keep in mind that when you remove adenomyosis, as opposed to when you remove, let's say, a uterine fibroid, you are absolutely removing myometrium. This is, again, an infiltrating condition. This is a condition that has gone through the fibers of the muscle, and you are going to remove part of the muscle. So it goes without saying that in that picture that Dr. Vidali was just sharing, you were removing half of the uterus.
This is, Antonio, the muscle with inside the islands. You see the muscle fibers.
Yeah.
And these are the islands of glands. You see the glands. If you guys remember from high school, these are the glands. And you see muscle fibers here, right? And you see tons of also inflammatory cells. So this is your typical adenomyosis. And
Andrea, can you put the other picture up when you're done?
Which one?
The one you first did. When you're done with this, can you put that up?
And this is a pathological, it's a cut from surgery where we could see what Dr. Gargiulo just was referring to, the lacunae, the islands, the holes, right? Here they are, the classic Swiss cheese appearance of adenomyosis here and here. You can clearly see them. Sorry, I'll go back to the thing. Antonio, didn't mean to interrupt you, but I wanted to...
No, please.
No, I had a question for Dr. Gargiulo, which that picture, it's a very good, the first MRI I think you had up. Good, okay. So Dr. Gargiulo and I discovered him in his adenomyosis brilliance at AAGL in 2019. And at that roundtable, a lot of the Canadians, because we were in Canada, had a discussion about doing a posterior uterine resection to something that looked a little bit like that. Can you talk about when it might be good to do posterior uterine resection and when it might be bad? Because from a physical therapy perspective, in terms of preserving the anatomy and keeping support to the body and stopping pain, it might make some sense, but there are some real reasons not to do it. Dr. Gargiulo?
So the issue is, all this area that you see that contains lacunae, when you remove it, it doesn't grow back. Some of the original myometrium is probably found posterior to that image, as you can see, all the way to the back. Mm-hmm. So you really have to study case by case. I cannot think of a situation in which the surgical strategy must be discussed more in detail, more image by image with the patient. That's something like this. This image that you just show pushes the limit. As far as I'm concerned, if you go for resection of that area, you have at least to tell the patients that the chance of a bad obstetrical outcome could be absolutely there. So because you're gonna weaken the myometrium to the point that they could have a rupture. They could have placenta accreta or percreta. That means placenta that grows through the entire wall. So this is a last resort type of operation.
Right, so that's more for people that are looking to preserve their uterus for other reasons than reproduction. And that's what he means by an obstetrics failure, because reproduction is obstetrics.
Well, okay, Doctor. It depends. I think, I just wanted to mention, we're going to talk about the OSADA in a second. I just wanted to quickly bring it up, but then we'll talk about it in a minute about what the procedure is. I think, before we go to that surgical thing, right? Because ultimately I think there's an algorithmic process. There's a decision, instead of jumping surgery, this and that, there's a decision tree here, right? Which is really, what is the approach, because ultimately, and what is the goal? Because I think if you don't separate what the objective is, you can't really decide what the plan's going to be, and I think that based on that, surgery has a place, I think, even in fertility in some extreme cases. And whereas, for pain, it may have a smaller place because obviously the surgical procedure is very aggressive and has a lot of complication potential. So I think we need to separate a little bit pain from fertility, I think, when it comes to adenomyosis. A little bit less, I think it's less true for endometriosis, where the operation that eases the pain also eases the fertility. I think in a way it's a similar operation, but for adenomyosis, I don't think it's the same approach. Do you agree, Antonio? Or I don't know if I expressed myself properly.
No, I agree. And also, if there is controversy in the level of surgery and the indication of surgery in some cases of endometriosis, we have to be very clear and candid that here there is not even controversy. There is complete chaos. There is absence of agreement at all levels on what you treat and do not treat, and if surgery should be done and shouldn't be done. The reality is that, that surgery for adenomyosis can result in a partial hysterectomy. What I mean by partial hysterectomy is that a vital part of the uterus can be removed, making the uterus an organ that's there just for presence, but not for safe reproductive performance. I want to go back to this point because the reality is that not everything that we can technically do should be done. And the reality is that we've become very good at uterine surgery, particularly laparoscopically, robotically. We do very complex myomectomies. But let's make it clear from the beginning that when you deal with myomas, you're dealing with hard tumors that push away the muscle. They don't infiltrate. They create volume. You remove that volume. You preserve the pseudocapsular space, which is the compressed muscle around. And that will, again, shrink down to almost identical muscle as it was before. Not so with adenomyosis. Adenomyosis is it's a lesion that's infiltrating the muscle, and the muscle that's been infiltrated is forever compromised, and the muscle that's removed with adenomyosis will never grow back. That's basically something that we have to say. Now, we also should remind people that we don't have a clear classification of adenomyosis yet, and there are classifications in radiologic articles and atlases, but the American Fertility Society, the American Society of Gynecologic Laparoscopies, American Association of Gynecological Laparoscopies. They don't have a validated classification of this condition. And they're probably, just as we now, now endometriosis has become more of a household name, right? We know that what's stage 1, stage 2, stage 3, stage 4, there is not such a thing for adenomyosis. But of course, there is going to be a different level of different staging at some point of adenomyosis. Adenomyosis can also come from the inside out of the uterus rather than from the outside in. There are probably 2 types of adenomyosis. There is a type of adenomyosis, like the one that Dr. Vidali was showing a minute ago, that clearly stems from the interface between the muscle and the inside of the cavity. There are also adenomyosis that come all the way from the outside and spare the endometrium completely. Those, particularly where small in volume, probably should be treated. Those are invasive endometriosis that has gone into the myometrium from the outside. In my experience, those are the ones that are more likely to have successful surgical treatment compared to the ones that originate from the endometrium, where you end up removing the whole wall of the uterus. So I don't know if you agree on that one, Andrea. And this, we should be humble about the fact that these are very personal opinions. We are not supported by any major medical society recommendations here, because the field is truly young.
Dr. Vidali, your mic.
That I was pulling some stuff, some videos up. I agree with you 100%, Antonio. I don't think there's any agreement on that. The reality is that most of the time when you see adenomyosis surgery, at least in the fertility patient, is when the doctor thinks he's going after a fibroid, goes in there. The doctor has not done their homework, has not done an MRI, has not done enough evaluation, starts cutting, and guess what? There is no capsule, and they're dealing with an adenomyoma. So because they're not prepared to do the actual operation, some sort of a half a whatever job gets done. And, the uterus ends up, getting half butchered with like a lot of adhesions, and the patient's worse than before.
Dr. Vidali, lots of questions on your concept of white blood cells and fevers and this immune response. So feel free to parlay into your...
I just wanted to show a video because I think people may be interested in this. I want to show a brief video, the 2-second video, but I wanted to show, it could be a little graphic. Maybe I shouldn't show it actually, now that I think.
No, go ahead and show it. We're going to just issue a trigger warning. Close your eyes for a few minutes if you don't want to see the video, but if you do want to see the video, here it comes.
Yeah, it's going to come in a second. Okay. I'm just going to go just 1 second. So, 1 second. I gotta silence it. Here we go. All right, so I'm going to share my screen for a second. What I want you to see is what actual adenomyosis looks like when it's actually cut out from the uterus. Just 1 second. The interesting thing is that it's almost bloodless. Can you see the screen now? Can you see surgical image?
Yeah, we can see.
Yeah, well, you could see this being cut out. That's adenomyosis. You see this thing here? This thing here? That's part of adenomyosis of the uterus. And you could see that it's a very, very, it's like a chunk that doesn't have any, it's not even bleeding. You see that? It doesn't have any, vascularization. It's a typical thing that when you're cutting into adenomyosis, it's dry. It's completely dry. But you can see here in the background, the uterus is splayed out and open. It's a very, very aggressive operation. I'm going to go back to the regular thing, but you can see that there's almost no vascular supply to the uterus, to the adenomyosis itself. It's very interesting from that perspective. And this is why, when Antonio says, well, you're removing muscle, you're removing really kind of tissue that is almost non-functional. Now, whether or not you should remove it or not, that's a completely different story, right? And that's part of a longer conversation that whether or not that's done. And I think that, but there is no recommendation, and very few people are doing adenomyomectomies or aggressive adenomyomectomies because they're complicated surgeries that have a high, even the surgery itself has a high complication rate. You know, and I'm talking about blood transfusions, I'm talking about infections post-op. And so this is not a simple surgery to do, and it's not recommended to everybody, but there are some cases where it may be indicated, I think. But, you know, that's really, but nobody, like Antonio just said, there isn't any sort of sanctioned reproductive or medical organization that has said, this is the way you do it. The general consensus is, you know, if you have adenomyosis, you get a hysterectomy if it's really bad. And that's really pretty much what it has been. But individuals, people, folks, you know, they will make their own choices, I think. And sometimes you make choices that, you know, you are aware that it involves some risk, but you do it because, you know, you're a person and you have, you know, you're allowed to self-determination and make your own decisions, I think.
So, and also, I wanted to share one video I think may be interested, and it may be interesting. Do you mind if I share it now?
Of course.
Oh, we'd love it. It's hilarious, though, because this one was going to be made into a podcast, but now you're doing all these visuals, and I don't know if we're going to be able to do that.
It's still going to be good. Don't worry. So far, it's been a very, very stimulating conversation, yeah. Sallie. I mean,
so this is a single site adenomyomectomy. Forget about the single site point, which single site suggested that this is very focal pathology. And where this probe touches there, that's adenomyosis, whereas the outer part that looks more like a whiter layer, more organized, that's the muscle fiber. And you can see that as different from what we do with fibroids, where you can find the capsule that Dr. Vidali was talking about. Here, you have to carve it. You have to carve out this focal adenomyoma. This is a focal adenomyoma. This is, it looks like a big thing. I assure you, this is less than 4 centimeters. The whole lesion is less than 4 centimeters. It does span, of course, you know, a critical part of the uterus. That's right at the fundus and the anterior upper portion of the uterus. That's the cavity where that ink is coming out of, that it looks like there is fluid coming out that's blue. I don't know if you can appreciate the blue fluid. And that shows you how close to the cavity you have to go to remove even a focal adenomyoma like this. And this is the adenomyoma being carved out. So that's what you have after. So you can appreciate how, you know, this is now a crater that has to be closed in layers very carefully. And I don't know if the upload speed is good enough that you can follow it.
Not only we can follow it, Antonio, but it's absolutely beautiful. Absolutely.
So Antonio, it's a perfect opportunity. And what is your favorite tool to use to carve out that adenomyoma?
My preferred tool is laser for many reasons. The laser knife is it's a tool it's a cutting tool that has no lateral thermal spread, but it's very precise. It does, because it doesn't burn the tissue when you get close to the endometrium, you're able to still build a good plane that doesn't affect more than the tissue that you are seeing. So what you see is what you get with the laser, in that you cut and you know that you're not going to have like necrosis, like death of tissue from a heat injury that goes beyond what you have seen. So this, again, this is a closure in layers of that defect.
That's amazing.
Yeah.
That's just incredible. That's incredible. I'm so glad that you shared this.
So that we're clear. We're not gonna, you know, the uterus is still there. I have to tell you, this video we showed at the SRM. That's the incision. That's the only incision, by the way, that we do for this operation. But this is these are chosen cases where we can do a single site surgery. That's the scar.
It's absolutely beautiful. Amazing job. Meanwhile, I wanted to show you what a radical adenomyomectomy looks like. The uterus is like a ghost of its original form. And here we go. Again, you know, you could see that the uterus here, you could see there's no fallopian tubes. The uterus is like reduced to like, you know, basically folded upon itself. This is open surgery, of course, because it's a massive operation, and the uterus is reconstructed, but very few connections. You see that it's completely, you know, reconstructed but this
now,
yeah,
when we decided to have a second endometriosis summit, because remember, this was all like kind of a thing we did on the whim, but when we went forward with the second one, I actually contacted Dr. Silber, right, who you brought up his article, and he said he doesn't really do the procedure anymore because there is massive tissue damage. And that he wasn't finding that people were able to carry and conceive anyway. And so he wasn't sure, and we had a long talk about it, and he wasn't sure if he should continue to advocate for a procedure like the OSADA procedure. You've done a few. Yeah. What is your opinion on that?
I agree with that. I think that it's not a procedure that I routinely offer to people. You know, at the most, I'll offer somebody like you just saw Antonio's, the way he did it, you know, something similar, not as elegantly. That was a beautifully executed procedure. But I think that I agree with Antonio on this. It can be done. And I think there are specific individuals that will say, look, I don't care. I just don't want my uterus out. Whatever has to be done has to be done. And I respect that. But overall, I think that, and for some people, I have to say that their symptoms are so dramatic, are so crazy that they're not living. So, you know, of course, the only option is going to be a hysterectomy or doing that with the understood risks or uterine rupture, premature birth, and all those things. But for some of these individuals, there is no alternative to a hysterectomy, with the exception of doing this type of radical procedure. So it's one of those ethical decisions. You understand? I think it's one of those difficult ethical decisions where I think it's not very easy. There is no easy conclusion, and you can't go by guidelines because there is self-determination of the individual. There is personal reasons, financial reasons, ethical reasons by which people are not going to go forward with a surrogate. And so like, that's really where you're at, I think, with this type of decision. So I respect it when people say, look, I don't care. I know the risks. I still want to go forward with that. And I think as long as they're informed enough, I believe in self-determination.
Right. So we'll just, we'll put it, since we're patient and practitioner entity, I did not want a hysterectomy, and we could say I had significant adenomyosis. Now, I had a posterior uterine resection sort of without consent. And while it rendered me unable to carry, it tremendously fixed my back pain. The back pain that I have really comes from the hernia and the nerve root, but it changed my sacroiliac joint forever. And it does work. It did not allow me to carry a child. But I decided, and I made a choice to have also at a later date, the adenomyomas removed. And it made a huge difference in my bloating and in my overall like illness all the time, but it meant going through multiple surgeries. I then had a complication, which was a little related, but not really related. And had I not gone into menopause at 42, we might still be sitting here in horrible pain and not running the Endometriosis Summit. So there are people who make a choice that the adenomyosis is causing them to be very, very ill. Is there anything, and they choose to have a hysterectomy. As a PT who was heavy and athletic, I did not want to alter my anatomy like that. That was my choice. I'm curious, what are each of your opinions on the presacral neurectomy? Because as a PT, I also have a strong feeling about that too. Dr. Vidali.
I don't do much presacral neurectomy, I have to say. So if you have more experience, you're welcome to go first.
My personal opinion is that I don't perform that procedure, although it's very easy to do. Technically is extremely easy to do. My issue with the presacral neurectomy is that, first of all, Denervation procedures in general always result in recurrences. There's almost no denervation procedure in medicine that doesn't have ultimately a recurrence, because nerves have their way to find their, paths somehow. So you cut a path off and a new path develops. So that's one part of it. And the second part of it is that it's rare but possible. Chronic constipation from, in rare cases, but from pre-sickle neurectomy can result. It can be very continuous and severe, and also bladder problems. So it's not something that I recommend, but I know that there are studies, and I know that there are, some centers that perform it very successfully with good results, and they continue performing it. I personally, I have very low tolerance for even the very low rate of complication for it. And I think the benefit is limited. But like I said, there are centers that are doing it and very successfully. So I'm just talking from my own experience.
Now let's talk a little bit about people who have had a nice endometriosis excision, who are not looking to conceive, because that changes what you can do, but they may want to try different hormonal management instead of a hysterectomy. What are those options, Dr. Gargiulo?
I mean, I have to tell you, one of the simple remedies to try, for me, first line is an IUD. The IUD has saved more uteri in my practice for women that don't intend to conceive, of course, because then that's a very effective contraceptive. But in many of my patients, the IUD specifically for adenomyosis, and we're talking about the IUD that delivers levonorgestrel, which is a high potency progestin locally to the adenomyosis, because it's literally lying millimeters away from the adenomyosis. It has reduced the symptoms, both the bleeding and the cramping, dramatically in many of my patients. So that would be one. So progestins locally. The other one would be progestins orally. And in my experience that you have with adenomyosis, you have to go heavy on progestins, and progestins have several side effects. The weight gain, the mood changes, depressogenic, particularly acne, and they're not easy to tolerate. So my experience with, for example, norethindrone, FDA-approved progestin for treatment of endometriosis, which can definitely be applied to adenomyosis, has not been great, because it probably works well starting at 10 milligrams a day, which is a high dose. We also have a limited number of progestins, frankly, here that we can use. Norethindrone tends to be my favorite. And, beyond that, I can see on the chat right now, what about Lupron as a treatment? That's a question. So Lupron, the issue with Lupron is this. You can only, Lupron is what we call a effective, non-sustainable treatment. That means that by the time you are done a bit, adapting to the side effects, it's time to go off. So when you find out that Lupron works, you have to go off of it. Now, you could do, if you want, in a not FDA-approved fashion, and followed by, truly a reproductive endocrinologist. You need somebody that really knows what they're doing with hormones. In an off-label fashion, you could do solid high-dose progestin with Lupron, and probably you can sustain that for, instead of months, sometimes years. But that, again, this is
but by then you will weigh 300 pounds. You know, yes, what I'm saying?
Right.
With
I wonder.
Yeah.
Somebody asked about Nexplanton
on both sides. Yeah.
Somebody asked about Nexplanton on Facebook instead of the IUD. What is your experience with that? We are speaking tonight specifically to adenomyosis and not to endometriosis. So what is your experience with that?
I have not used the Nexplanon on these patients. Have you, Andrea? I have not.
Yeah, I mean, the problem with Nexplanon is that the erratic bleeding that happens with Nexplanon, because it doesn't really suppress ovulation, very solidly most of the time, is that any episode of bleeding in patients with adenomyosis results in terrible cramping and more inflammation. And so like it creates a vicious cycle that I think it's just not there. You need sustained, consistent levels. So if you're going to hit adenomyosis hard with hormones, it's high dose norethindrone. That's what you're going to use. Or, you know, if the IUD doesn't work, you know, high dose norethindrone, agestin, basically. That's the
well,
only.
and you've even said to patients, Dr. Vidali and I share patients, but you've even said to, say, a 25-year-old who wants to put the IUD in to try to extend the uterus, that after 2 years or sometimes even after 18 months, the dose isn't as high in that IUD, which is not proven. But do you want to explain that a little bit, Dr. Vidali?
I mean, like the IUD, Mirena IUD is obviously is designed by design is a contraceptive. It's not a hormonal therapy for endometriosis adenomyosis, you know. So it's like when you take a tea bag and you put it inside tea, after a while, you know, there's not as much tea coming out. You know, if you move from one bag from one water to the other water to the other cup. And, you know, you have to think about the Mirena IUD the same way. So the actual, you know, the constant delivery of the hormone with the Mirena is sustained, and ovulation and suppression of ovulation happens consistently up to 1.5 years, 2 years. After that, you don't have any more suppression of ovulation, and you basically have pure contraception just by presence of a foreign body. So then if you're giving Mirena for adenomyosis, you got to replace it every 2 years, 1.5 years, 2 years. Yeah.
And sometimes insurance doesn't.
It's not a bad deal. Not
right.
a bad deal.
And sometimes insurance doesn't like that because they're supposed to last 5 years.
Well, you're going to say, you know, sometimes they fall out or they're in a bad position, you know.
I'm curious, we have some Europeans here. What is your opinion of Visane specifically for adenomyosis, not for endometriosis?
Andrea, go for it, because I mean, Visane, it's impossible for me to find here, of course. So I don't have a specific opinion. I'm not aware of a lot of studies on adenomyosis, frankly.
Visane, you know, Visane is a good drug in general. I mean, it's a very good alternative to agestin. It's less androgenic, less symptoms. It's basically a more tolerable progestin with less side effects, less weight. The androgenic component is very important, because one of the problems in norethindrone acetate or agestin is that it's a powerful androgen. So patients who are on high dosage of this stuff, especially if they're prone to having, you know, more hair, they're going to see even more hair. They're going to see acne. They're going to see a lot of side effects. Whereas, you know, hair loss, of course, and you're going to see less of that with Visane. I mean, none of these, you know, the reality is none of these hormones are really amazing. You know, each one of them is a compromise of a different type. But I do prescribe it. I tell people, you know, I give the prescription and buy it in Canada on those international pharmacies, or in Europe. Yes, I think it's not a bad drug at all.
So I'm curious, Dr. Gargiulo, and we have a lot of questions. I'm going to ask this, and then I'm going to ask some of the questions from the crowd. With adenomyosis, since it's so common to have adenomyosis and to have fibroids, are there issues with giving progesterone? Because progesterone does one thing for one and one thing for the other.
Yeah, that's a very good point. The reality is that, yes, they can coexist, as we know that also endometriosis and fibroids can coexist. It's unclear to me, frankly, whether they coexist specifically for some genetic reason or just because they're two very common conditions of the human, right? But you are right. There are some fibroids, and we don't know which they are, that will specifically react with growth, cellular growth. So an accelerated growth when challenged with progestins, not only estrogen. That's clear. And in fact, one of the proven medical treatments for uterine fibroids is the receptor modulators for progestins, the selective progesterone receptor modulators, currently, of course, undergoing very, big scrutiny because of some liver issues that have occurred, but nonetheless, a highly a promising group of drugs, which we're keeping a very close eye on also in the United States. But at this point, so to be clear, they're not available in the United States. They've been suspended in Canada, and they had been suspended by the European.
I want to mention to our listeners what the name of the progesterone modulators are, Antonio.
Is the
because I forget, I don't remember.
Ulipristal.
Yes.
Ulipristal. So and also in Europe now they were suspended for a year, and now since November they're back on the market, but the specific black box saying that they can only be used in cases where surgery is not feasible or not recommendable. So they really restricted the use. But your point was very well taken. You have to, if you are giving progestin to somebody with adenomyosis, they are stuck between a rock and a hard place if they have fibroids, because fibroids may take off. The issue with fibroids is that eventually a fibroid, it's eminently amenable to surgery. We love doing surgery for fibroids, and we think that we can reconstruct the uterus very well. So that is no longer, the myomectomy is really no longer the big frontier. I mean, myomectomy is a standard minimal invasive operation most of the times. So if needed, eventually one can do the myomectomy. The reality is that the real beast here is adenomyosis. With adenomyosis, the reality is, what can you do? I see a lot of questions in the chats and in the Q&As. I mean, what really can you do? If you are unlucky enough that you get an adenomyosis diagnosis remote from the time where your reproductive endeavor begins, and the reality is not much, because you can try the IUD, you can try the progestins, you can even go nuclear and try the GnRH agonists, but the reality is that at this point we don't have a very good weapon against adenomyosis. We also, frankly, do not know how much adenomyosis is too much adenomyosis that truly will impact, because when you look at the papers on does adenomyosis impact live birth rate, they will not tell you, diffuse versus focal versus an cystic adenomyoma. They lump everything together. So everything together, we know, yes, it impacts live birth rate, right? But there may be adenomyosis that doesn't impact that much. And that's why it's not like a death sentence on your uterus, the adenomyosis. It has to be well understood. I think that one of the big messages I really wish to give to patients with adenomyosis, imaging to the ultimate level. So really have imaging, have multiple surgical consults before anybody touches the uterus surgically, because the removal of adenomyosis can help in many cases. I think it can also damage irreparably the uterus in many other cases for something for which we really don't know exactly at which level, what kind, and what volume of adenomyosis truly is affecting implantation.
And then no, it does affect it. No, there's no question. I would
like. Those are the next questions, Dr. Vidali.
I would like to, sort of like make a slight amend to what you just said, Antonio, which is like, we don't know to what degree it affects implantation. We know it affects implantation, but we don't know the degree. But there's certainly a reduction in implantation and an increase in miscarriage. Paolo Vercellini had a very large series on this, and it's very, very good data. 2014, I was trying to pull a paper, but we're talking and I just can't do everything at the same time. But
Dr. Vidali, a ton of questions on how does adenomyosis affect implantation, and what can be done to modulate that effect, either when you're implanting through IVF or you're trying to get pregnant naturally.
Well, let me just say first that to complete that sentence in saying that it affects it. Nevertheless, Antonio, and I think you feel the same way, I've had cases of individuals with extremely significant adenomyosis where I thought, oh my God, this is never going to happen, where they actually were successful. So, you know, I never say never. That's the first thing that we have to say in anything. Never say never in anything. And I think that, you know, I'm lucky that I have the gray hair. You know, you're not going to see it on the podcast, but, you know, I don't have still, you know, Antonio still has some, you know, brown hair. I've gone completely gray and white. But, you know, what I think is that I've seen it over the years, cases where I thought, and even recently I had like a case where I was like, this is a tough one. And I was talking down with a doctor down in Maryland, and you know, I helped her with the IVF, and I was doing the immunological part, and she was successful. And I was like, wow, you know. So it's not like a death sentence, like you said, but there is certainly an impact. How? Inflammation. There's only one word, and that's inflammation. It's an inflammatory condition, and the inflammatory cells that come into the uterus ultimately, because of proximity and a number of other factors, alter the behavior of the T regulatory cells at the level of the uterus, and ultimately, you know, affect implantation. There's also vascular changes in the uterus for diffuse adenomyosis, where typically what you will see, because, you know, you remember these islands inside the uterus in the muscle distort the cytoarchitecture of the uterus itself, and the vascular, those little vessels that go through the muscles get broken down. And so the blood supply, you know, those spiral arteries that have to grow, and, you know, like they also get disrupted at the level of after implantation. So what you will see is reduced blood flow to the endometrium, which usually results in many adenomyosis patients with thinner linings. The paradox of the adenomyotic uterus is like big uterus with thin lining. And because of the low blood flow, reduced blood flow, you're going to see a faulty implantation, superficial implantation of the trophoblast, that then results in pregnancy complications. So it's multifactorial, but definitely the immunological component, and as you know, guys know, for me, the immunological component is always very important and crucial, because there has to be an understanding that inflammation equals faulty implantation, because it alters those very, very delicate mechanisms of development of immune tolerance into the uterus. And I think that's very important. And many of these patients with adenomyosis will have very elevated white counts. They'll have a white count. Typically, they go to the hospital with pain. The doctors draw the blood. They see white count, you know, 15, 18. They say, oh, you have PID, when instead it's the adenomyosis. I've seen it many times. They get fever when they get a period, typical other symptom. I mean, these are, you know, of course, extreme cases, but not as uncommon as you might think. I mean, you have seen that, right, Antonio? Like these crazy things.
Oh, yeah, no, absolutely. Yeah, and they're treated for endometritis, or as you say, you know, PID.
Yeah.
Yeah. You know, go ahead. Sorry.
I not to interrupt, but it was interesting when you're talking about inflammation. I spent the day really researching heart rate variability as a measure of systemic inflammation. And when we talk about preserving a uterus or what can somebody do, it's very hard to look at what can they do direct to the lesion or to the gland itself, but what can they do systemically to change that profile. We're going to ask one more question, and then I'm going to ask Dr. Gargiulo about something very specific. But for somebody who has all the pain and quality of life issues with adenomyosis, when would you say somebody is too young for a hysterectomy, and what might go into the decision of choosing to have a hysterectomy for adenomyosis? Dr. Gargiulo, you begin.
Well, I mean, one can certainly extrapolate data that we already have for even simple salpingectomy or sterilization. You know, if you do a sterilization, even after having had plenty of children before age 25, your chance of serious regret leading to search for IVF or a reversal of sterilization is over 30%. So it's like Russian roulette with 2 bullets in my book. So you're very likely to regret that at age 25. Now we're talking about, in this case, you specifically said when you are remote from, you know, you're young and remote from from completing a family, right? You're not talking about a 30-year-old who has 2 kids and could be fine with parting from the uterus, because, you know, really, when it's too early for a hysterectomy, really depends also on whether you have completed your reproductive endeavor, right? I mean, that's basically what we have to discuss. So
yeah, but Antonio,
you know,
sorry if I interrupt you. We don't have a lot of time, but you know, for the sake of the conversation, I'd like to say this: that you know, we come, you know, from as doctors, we also have to. We cannot be paternalistic, and we can't assume that every person should have a child, or we can't even assume that every person should want to have a child. And when somebody comes to us and tells us, I don't want to have kids, I've thought it out very, you know, in depth, and that's my choice. You know, it's easy for us to say, oh, you're too young. You're going to, you know, as you get older, you're going to change your mind and blah, 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 you know, but we have to remember that we are not these people's parents. You know, we have a responsibility as doctors, but also people make their own decisions. You know, you could do so many things when you're young and make so many decisions that you come to regret. So many, but you still can make all of them, you know? So I think that, you know, from an ethical standpoint, I think some of it should be discussed. And I always try to, you know, personally myself, I don't tell people, oh, you should think about having kids. I always tell, look, have you thought about all these different things? I never tell people you should think about that. And when people say the concept of regret, that's a medical legal issue, right? Because you're worried that people are going to come after, you know, us and say, hey, you allow me to have a hysterectomy, and look at me. Now I'm like, whatever, and I change my mind. But I think that self-determination has to be considered. I don't know how Sallie feels about this. You know, I don't know.
So, I mean, first of all, there are many reasons beyond reproduction to want to keep your uterus.
Right.
And there are many reasons beyond reproduction to want to get rid of your uterus. And if somebody if somebody is not able to live the quality of life that they desire, and this is the true cause of their pain, then it's their choice to enter into this discussion. But at least once a week, I see a hysterectomy done. The person still has endometriosis. That happens all the time. A 22-year-old chose to have a hysterectomy. They still have endometriosis. We shouldn't be going through that. I also see tremendous multiple generators of pain, and yet taking away the uterus isn't going to fix this. So Dr. Lariche was on with us on Instagram. You know, we know the bladder generates pain. We know S2, 3, 4 generates pain. We know the pelvic floor generates pain. We know hernias generate pain. We know there are lots of causes of pain. And so if you think a hysterectomy is a magic bullet, then that may be somebody at any age you have to counsel. But you can enter into the decision to have a hysterectomy because that's what's going to change your quality of life. What I don't like, and none of us like this here, is this overall thought that you go and have excision. Maybe you do 6 weeks of kind of crummy physical therapy. 6 weeks is like nothing, because most of my patients are seen for a year or more. But you do, and then after you had that excision, oh, I still have pain, must be adenomyosis, gotta go have that hysterectomy. And so it's become this culture of a lot of people, you know, oh, I had adenomyosis, I have to have a hysterectomy. No, it's your choice. It's something that people genuinely, I believe, should have counseling at their own doing, not because a doctor chose them to do, to explore how they feel about it. And I think that hysterectomy can play a role, but you have to understand, you know, what it's going to do to you. And for some people, it changes their life completely, because they can go to yoga and go out and do backflips and do whatever, have painless sex for the first time. And that was totally worth it, worth the exchange of not being able to have a child. And for some people, that's never going to be worth it. And for some people, they have to make peace with either side of it. So
amazingly said, right, Antonio? I mean, she couldn't have said it any better.
I mean, you know, patient selection is very important. I mean, because, you know, we know when adenomyosis is there 98% of the time. I mean, it's not like a shot in the dark. I have to tell you, the more I operate, and the more I tell you that the consult time that goes into making a decision like this should be at least 3-4 times the time of the operation, because the operation for adenomyosis is not a difficult operation, the hysterectomy, but the counseling about it should be 3 or 4 times as long, because, you know, once you decide, we'll do it. That's, you know, that's basically what happens. So, and once it's done, can't be undone until we do the uterine transplantation, of course, which is serious.
Right.
For
Well,
the,
that's the
you know,
next question. But so I will say, Heather Guidone of the Center for Endometriosis Care, she always says hysterectomy is a bell that can't be unrung. So you need to enter into your decision with full education and have peace with your decision. Let's talk very briefly.
Can I add one tiny more small thought before we move on to transplantation? And this is the thought. Sometimes people will come and they will have a molecule of adenomyosis seen in the uterus, a tiny, tiny bit, okay? And if you look for it with a microscope, you'll find it. And you know, and then the question is, okay, that's the adenomyosis, this is why the pain. And there is also this clinical entity, which is the tender, painful uterus, which is a uterus that whenever there's a menstrual period, although it doesn't really have any adenomyosis or anything much going on, is extremely tender. And there's extreme pain, extreme, which is probably due to sensitivity to prostaglandins. It's a real condition, okay? And it has nothing to do with adenomyosis. It's a separate condition, the tender uterus. And you know, there's different options for it that, you know, we're working in, you know, Botox of the uterus. You haven't heard that, you know, it's an anticipation.
We're gonna have to do adenomyosis part 2 during our summer season.
So like, you know, we'll talk about it. It's an interesting thing, but
right.
you know, like that's what we're working on, so that you know. And that's what I want to say. But don't think that the little tiny bit, that tiny bit is the cause. I just personally, I am not convinced that that is the case, clinically speaking, and in many, many years of this. Yeah. Sorry.
Antonio. And I also see a ton of pain that people think is, oh, I have adenomyosis. No, you have a diastasis. So that's why you have midline pain, or you have, you know, there's a lot of other reasons. But Dr. Gargiulo, let's very briefly talk about uterine transplant, because until I read your blog on Resolve New England, I did not realize that that's something that's feasible for anyone. I thought it's just something we were like doing for the sake of doing. Go ahead.
No. This is not for the sake of doing. This is, let's make it very clear. To me, the operation that goes into the explant of the uterus from a live donor I'm talking about is probably the most difficult gynecologic operation I've ever seen. So it's not easy. The whole process is complex. It requires the making of embryos in advance, making of multiple euploid embryos so that you have a reasonable chance after the transplant has been done and successful to do embryo transfers with a reasonable chance of success. But it's very real. And I want to point out to the fact that there have been about 70 transplants done worldwide already, and about 30 babies have already been born. Now, compare that, for example, to the first 130 cycles of IVF done in America, when in England they already had started and been successful. The first 130 cycles did not result in a pregnancy, so that we're clear. And back then, we're talking about the Dr. Jones, right, at Fairfax. IVF implied an operation. Yeah, in Virginia. So yeah, you know, you had a fantasy like a C-section operation every time they had to retrieve eggs. This is serious stuff. They did 130 before they had a single success. Here we're talking about a procedure which is highly complex, but also highly effective, because out of 70 people, 70 transplants, we have already 30 babies. So, and this is just off the bat like this. And the reason is, and we should say it, is because it is a technique that was developed without rush over a period of no less than 15 years by the team in Gothenburg. I mean, this technique has an address, and it is the Sahlgrenska Clinic in Gothenburg, Sweden. This is the place where this has been organized for 15 years, starting from rats, mice, other animals, some of which are pets and we will not name, then monkeys, everything. They've got pain, you know, but eventually when they did it on a human, it worked like right away. So this is a real thing. And also, even beyond that, when this was replicated with good guidance from the original people in the original group, for example, the group of Giuliano Testa hired Dr. Johannesson from the original group, they immediately got success, which doesn't mean that this is an easy procedure. It's very difficult. Ethically, it's very difficult. It took us a year to get the approval, for example, for deceased donor uterus, from the uterus from a dead person. It seems like nothing, like you would think nothing of it. You say, oh, the person is dead, you can get their uterus. A year of ethical committee trying to get through the permission to do that. So this is, this is very controversial, very difficult, but again, very efficacious. And this is important because to me, eventually, this will become a procedure that one can discuss as a real alternative in appropriate cases for women, for women for which the gestational carrier option, as Dr. Vidali was hinting before, is not acceptable. Because one should remember that whereas in most states of the federation, it is legal, even though the legislator in most states, again, is not clear, and you need lawyers that cost a fortune to go through this effectively, through this process. In the quasi-totality of states and nations on earth, this is an illegal practice, the gestational carrier practice. It's only legal specifically at this point in Russia and Ukraine. We're not talking about gestational carrier without commercial mercenary payment of the carrier, which is also legal to a certain extent in Canada and the UK, but it's minimal. It would be like, if your sister carries for you. But the reality is that this is forbidden in most nations, whereas uterine transplantation is not going to be. So what I think the future of uterine transplantation is going to be is that eventually it is going to be just like another transplant, like kidney transplant or liver transplant that seemed like, crazy stuff 60 years ago for kidney transplant. And, now you can do a lung transplant, which when I was a medical student was like complete experimental surgery. And now there are programs of lung transplant, and there will be programs of uterine transplant. Absolutely, there will be. So the difference is that in some states now, in many states in the federation here, fertility treatment is considered a treatment that health plans have to cover. And that's where there's going to be a big difference, right? Because let's say in New York or Massachusetts, if you have insurance, at some point, if this becomes, as it will become, an accepted non-experimental treatment, because they won't cover experimental, but if it becomes non-experimental, and at this rate it will be covered. So the panorama will be very different, and people will be able to have a uterine transplantation for, bad adeno, or, post-hysterectomy for severe dysplasia, early cancer, et cetera, et cetera.
So that is the next frontier, Dr. Gargiulo, right?
Yeah, no, it definitely is. And it's never going to be easy. Again, we're talking about an ephemeral transplantation that is an organ that will stay in you just as long as it gives you time. At this point, most centers and the American Fertility Society recommend that after 2 births, the uterus should come out, because I want everybody to understand that this is a true transplant and you need continuous immunosuppression.
And by the way, Antonio, let's point out that these patients do not have miscarriages or have a very miscarriage rate.
Very, very low rate.
And
high immunization rate.
Yeah, and it's because they're all immunosuppressed. Yeah, exactly. It's the immune. You're modulating the immune system, and these patients don't have any miscarriages.
So our dream is my new dream is to show one of these uterine transplants live. I think that'll take a little while for the Endometriosis Summit to produce. But our closing thoughts tonight, Dr. Vidali, you start with your closing thoughts.
Well, my closing thought is that I love Dr. Gargiulo. I love Dr. Gargiulo. I think he is eloquent. He is a very compassionate human being and also an amazing surgeon and fertility specialist. So thank you, Antonio, for giving your time. I think that somebody of your caliber to have you at these live talks is a gift to all of our patients. Thank you, Dr. Gargiulo.
You're kidding me. It's a joy, honestly, to work with you guys. And in the end, think how many people really, truly do the level of education for patients and physicians.
I wish more physicians watch this. True.
Yes, that you have been doing, for you and Sallie have been doing consistently for many years. I mean, this is it's a great platform, and of course, I'm honored to participate anytime, and it's always very stimulating, and you always find a way to disagree with me on a couple of points, which keeps me honest.
Just like we do a big long season December to March for Endo Summit Live, we're going to try to do a shorter season, a summer season, and hopefully we'll have Dr. Gargiulo back, because there's really just so much on adenomyosis to cover in one night. Next week, it is National Infertility Awareness Month week. I understand we like to talk about quality of life, but endometriosis includes everything. So we will have a very specific fertility talk. I have just booked a social worker, and I'm looking to book a couple other advocates. If you really have a crazy story, also please reach out to me on Instagram, because there's room on the panel for next week. But the other thing is that we will either be Monday or Tuesday, and it should be lots of fun. And then that's where we're at. We're planning Endo Summit 22, and we hope to be hybrid, and we miss everybody, and we hope you have a great night. Take care, everybody.
Bye, everybody. Thank you.
Thank you.
Bye, guys. Bye-bye.
Okay.